Good Friday morning, everyone. I'm Dr. David Wild, Vice President of Performance Improvement here at the University of Kansas Health System, sitting in this morning for Dr. Steve Stites, our Chief Medical Officer. We're coming to you live from the Dolph Simons Jr. Family Broadcast Studio. In studio, joining me today, Lance Williams, Supervisor of our Infection Prevention and Control Department, and of course the one and only Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control.
Yeah.
As we get started this morning, Dana, what's it look like out there?
It's getting worse for sure. We were down in the low 30s and high 20s. I was really not expecting to see the numbers today. Today we were up to 36 in-house with 11 in the ICU and 4 on the ventilator, but we still have 33 in that recovery period. So almost 70 patients taking up beds right now who otherwise shouldn't be here. In Hays, they're doing a little bit better. 15 total people in the hospital, with 11 of those active and 4 of those in the recovery stage, luckily. So hopefully they will maybe be able to be discharged soon.
Yeah, that's definitely an improvement there. And I think it points out this normal waxing and waning that we see. We have heard, I think, across the metro this week that earlier in the week most places had higher numbers, even a couple of systems that had over 100 total in their hospitals in the metro. So I think that's all consistent. Before we dive too far in to any of those details, though, Jill, are there any questions from reporters today?
I do have one from Channel 9. They want to know, which you just kind of said, are COVID cases rising sharply across the country? With COVID cases rising sharply across the country, a number of states are starting to report capacity issues at hospitals. Are you seeing an uptick as well? And what are your concerns about moving forward? So that's the whole topic today, really.
It is. That is, the topic of the day. I think, Dana, you've talked about what we're seeing acutely for COVID.
Yeah.
I think we would all agree, and Lance, you may have some perspective here too. I think we'd all agree that we're not flooded or overwhelmed with COVID-positive acutely ill patients, but that the strain that the patients that are positive and are here is creating is real.
Yeah, and I think as we brace for cold and flu season as well, that additional strain, we want to try to plan for that. We presume that the things that we're doing to prevent coronavirus transmission should help with the flu season, but a lot of that is still unknown as to how well that will help us here. So that's kind of a big focus for us, bracing now on what to expect with the Midwest spiking.
And I think as far as capacity issues go, it's not just the rooms and the ventilators. It's the people who can't work because they are either quarantined or they have the disease. It's the drugs that are needed. I saw an article last evening about 10 or so very vital drugs that people can't really get. Now, 2 of those were azithromycin and hydroxychloroquine, and nobody should be prescribing hydroxychloroquine and azithromycin for COVID-19. I think that's pretty evident. And if there's somebody that is prescribing it, it's actually going against current medical advice. But there's other more important critical drugs, such as drugs to keep people comfortable and sedated while on the ventilator, that other people may not be able to get who are in the hospital for other reasons and critically ill. So those types of capacity issues certainly were initially a problem. I think we've done better and have stores created now, but if we continue to see more and more, and our hospitals are filled with other normal illnesses and normal trauma and surgeries, that could certainly lend to drug capacity issues as well.
Yeah, I think I'll reinforce that to help answer the question just a little bit more. What concerns us and what are we seeing? We have 747 patients in our hospital this morning. 16 of them are in the emergency department, needing to be staying in the hospital, right, needing to be admitted and not actually able to be sent to a bed right now as we're trying to find the right place for them. That's not the ideal, clearly, for us, and we hear the same thing across the metro, across the region. But we also know, as Dana mentioned, that staffing, the ability to have healthcare workers, enough healthcare workers to take care of the patients that need to be in the hospital, is an issue. While it's not been a limiting factor for us here in our hospital, luckily, I think we heard from nearly every healthcare system in the metro this week that their limiting factor for the number of patients they can take care of is not physical beds, but instead the number of healthcare workers that they have that are healthy and off quarantine and able to take care of patients. And it doesn't matter if those patients are coronavirus patients or not, because there are a lot of patients that are very sick in our hospital. And so that capacity question is real. And I'll reinforce again that the solution to limiting that, the 70 or 80 patients, as Dana mentioned, that wouldn't be here if it weren't for coronavirus is really our problem. And so that impact and the impact that the illness in our community has on our healthcare workers is really, I think, where we need to focus our interventions, stopping community spread.
Is that all your slides?
Oh, we haven't got to the slides.
Okay,
We'll get to
yeah.
the slides in a second if
Oh,
we're
there's
ready. Yeah.
slides.
Yeah.
All
We're
right.
we're out of reporter questions. So.
Okay, so we'll come back to community questions, those that have been sent in this week and those that may be coming in today. It wouldn't be Friday with me sitting in the center chair if I didn't have slides for you. So
We love the slides.
here is a bit of an update for you. I'm going to start with the same pattern that we've shared the past few weeks, looking at national trends, working all the way down to what has happened locally here, addressing some of the concerns that we've been talking about for the past week or so. Maybe longer, actually. And this is a similar look to what I brought last week. The red lines here are the 7-day average number of daily new cases nationwide. The blue line is the currently hospitalized, 7-day average number of currently hospitalized patients nationwide. To continue to reinforce the point that as cases increase, the number of coronavirus patients in the hospital increases. We've seen it twice with the first and second waves in the spring and the summer, and we're seeing the same pattern now. And we expect, as we see this trend line of new cases increasing rapidly, that we will continue to see an increase in the number of people in the hospital. So the next slide moves just a little bit to show that the Midwest continues to suffer. Things haven't changed in a good way, at least, over the past week. The same colors apply here, red lines being the current number of new cases per day, 7-day average, the blue line being the number in the hospital in the Midwest region, and these are the census regions, if I haven't mentioned that before. So the trend continues. We've seen and heard across the Midwest that the number of COVID positive patients in hospitals in a number of states. I think this morning I heard 8 states again hitting record highs for the number of COVID positive patients in their hospitals, and most of those were in the Midwest. The cases and hospital lines trends continue to mirror each other here regionally as well. The next slide looks a little bit at population adjusted new cases to prove again that the situation is becoming dire in the Midwest. So last week when we looked at this, the population adjusted, or the number of new cases per day per million people in the Midwest, was somewhere in the 250 or 260 new cases per million per day range. This week, as of last night, that was 312. And that 312 is a bit of a scary number because you see the South peaking at 315. That was really the Texas and Louisiana experience in August and September. And you see the Northeast, the New York experience really, peaking at 317 new cases per million residents in March. So flirting dangerously with a number of new cases that has driven a pretty significant hospital surge and capacity question in the Northeast in March and in the South in the summer. Again, sobering numbers, definitely also showing that we are the highest as the Midwest. We are the highest region per capita number of cases of any region in the country at the moment. Moving to the state level to talk a little bit more about Missouri and Kansas, the trend lines continue to be up, although not maybe as steep as they would have been if we looked at this a week ago. So the red lines on the left side being the daily new cases, again, per million population. But you see how incredible the number of new cases, how really tragic the disease spread is in North Dakota right now. To put that in perspective, that 1,000 new cases per million They were actually at 1,016 at their peak earlier this week. New cases per million, the 7-day average, is higher than anywhere else, any other region in the pandemic in the world so far. And that's not too far off. Of course, on the right side, the blue lines for hospitalizations show that we continue to be at or near peaks in Kansas and Missouri for the number of COVID hospitalized patients every day, and that trend is not down. At least it's not increasing rapidly, but it's not down. And so to sort of anchor that with what we're seeing here, we've done this look before, then and now. These are numbers for our hospital. So comparing March and April in the left-hand column and September and October on the right for a number of categories. You know, Dana, I think you talked a little bit yesterday about October being our highest number of gross deaths for any month so far, and the month is not over, and that is definitely true. But there are some other caveats to that as we look through these numbers. And so we'll start out here just at the top, the number of hospitalizations. So the number of times a COVID-positive patient was acutely admitted to the hospital in March and April, 153 for that total 2-month period. So far for September and October, 309. So you can see the increase in the number of patients needing to be in the hospital over that time period. The average age of those being hospitalized is down slightly, 56 recently versus 59 earlier in the pandemic. And we've talked about this before, but this number continues to hold true. In March and April, about 5% of those that needed to be hospitalized for COVID had no pre-existing or no chronic conditions. In September and October, that percentage is 15%, so nearly 3 times the number of healthy people needing to be hospitalized now as we saw in March and April. And that's 3 times the percentage, not 3 times the number. 15% of a much larger number, really double the raw number of patients, is a pretty significant impact. Deaths in the hospital, so while hospitalized for COVID, you see already the number for September and October exceeding the March-April timeframe. It is important to mention, I think, that we do track deaths for patients after they leave the hospital as well. If they were to, say, go to hospice or a skilled nursing facility for care outside of the acute hospital setting but die, we do track those for a number of reasons. They're not the deaths that we report to the federal government as in hospital deaths. These numbers are here, but they're important to us because they help us understand what's happening in the community, and they're an opportunity for us to understand if there was any situation where we had an opportunity to provide care in a different way. But here's the important part, I think, of those numbers. The mortality rate for that time frame, 12.5% for March and April versus 5% now. So the in-hospital mortality, the percentage of the patients that are admitted to our hospital for COVID that die in their acute illness, is lower. Of course, a lower percentage of a larger number, though. A larger gross number means, by raw numbers, it has been, October has been the most deadly month of the pandemic for us. And you'll also see here that the average age of those that are dying has decreased. It's almost 10 years younger now. So when we talk about deaths following hospitalizations, hospitalizations following cases, yes, the percentage of patients that are dying in the hospital is lower. It's of a larger number. That means a larger number of deaths, but also healthier patients are here and younger patients are dying. And I think that tells a good story about what we've been seeing.
Yeah, and to that point, you know, it's not just deaths, because, again, people just looking at numbers, it's hard to realize these are our friends, our relatives, our loved ones. It is the people who continue to also have these chronic issues, and it's difficult to get out of the hospital. We have seen this. You know, we have 33 patients in the hospital right now who are in that recovery stage. You know, I've been contacted within the last week from a friend about a relative who is here or in the hospital who, albeit they're a little bit older but very active, but has significant complications now from COVID-19. You know, they didn't die, but we've talked about these long-term problems, whether it's the brain fog or the lung scarring and the lung fibrosis and inability to breathe correctly. So it is the deaths, the mortality rate, but it's also the long-term complications that really affect people and families.
So Lance, you mentioned earlier, one of the things that we're paying attention to, concerned about even, is that as cold and flu season really kicks off with a vengeance here, that will have an impact on our hospital, all hospitals really, as well. When you look at these numbers and sort of think about what bothers you or what's keeping you up at night, tell us a little bit more about how you think we can help better manage that, both as a hospital or a healthcare delivery system and then in the community.
Yeah, I think, you made a good point earlier that, this is prevention of coronavirus and helping out the hospital's function is happening in the community now. So it's human nature during the holidays to gather. And so that's something that me and my team are concerned about, especially going into kind of the three major holidays in our society. So, as we look at that, I think having the community think about their bubbles and think about their behaviors and what all the people in their bubbles behaviors are as well, because your risk is relative to the behaviors of everyone else around you. So it's really important for us to look at that and make sure that the prevention is happening in the community now, and that's the same with cold and flu season as well. So the things that we know work, masking, distancing, is going to be critical, especially now.
So one more slide to share, and I think it will maybe answer some of the questions. It provides a little bit of a snapshot of the impact on our hospital of COVID so far. So a whole series of statistics and numbers here that I think tell a little bit of the story, maybe in a way that we haven't shared all at the same time. So this is through Tuesday. 950 hospitalizations for acute COVID-19 disease. And when I say created by 891 unique patients, I mean that's 891 unique patients that needed hospitalized, some of them acutely more than once. So that means 891 patients. Most were admitted once, but some were admitted 2 times, maybe even 1 or 2 that were admitted 3 times in their acute phase for symptom management or other needs. 228 of those admissions have needed ICU care, and 129 of those in the ICU have required mechanical ventilation. Overall, patients are averaging about a 7 or 7.5 day hospital stay. Younger patients, if we look at age groups, are staying a little bit shorter time frame, 3 or 4 days on average. But nonetheless, the overall average since the beginning of March is 7.5 days in the hospital. Interestingly, we've talked about this being a local disease. The vast majority of the patients that have ended up in our hospital have been from our community. But that doesn't mean that we're not seeing transfers from all over our region and even really from a number of states. So 74 counties, those patients have come from 74 counties and 9 different states, from as far away as Washington or Louisiana or Texas or Florida. And many times those patients were traveling when they were ill or before they were ill and then needed care while they were traveling. Overall, to date, 10% on average have had no chronic or pre-existing medical conditions. So we talked about now that being 15% and early in the pandemic that being 5%. The average over the course of time is 1 in 10. And in the month of October, it's even higher. 21.3% have no chronic medical conditions. And I think that reinforces the fact that we're seeing younger, healthier patients need to be hospitalized as the population in our community that's being acutely infected, the new cases become more younger and more healthier patients. They're ending up in the hospital just the same. Yep. The average age to date of our hospitalized patients has been 55. But this isn't necessarily a disease only of those that are elderly. So 30 of those patients that have been admitted to our hospital have been 18 years of age or younger. And that is with, of course, an excellent pediatric hospital in town, seeing probably the majority of the pediatric cases that need to be admitted. 91 of those patients that have required hospitalization have died at some point. So again, that includes patients that have died after their hospital stay, if they went on hospice or were transferred to a skilled nursing facility. The youngest patient who has died was 21, and the oldest was 97. So again, quite the range. And I did want to share, just shifting completely from hospitalizations and deaths, just to talk about the number of tests that we've really been working hard to make sure we can offer to the community. So through Tuesday, we've done 103,229 tests in our lab. And when I say in our lab, I mean here in our laboratory on our hospital campus. But that doesn't mean that all those tests are from our patients. We've tried hard to be a resource for other hospitals that don't have the ability to test so that their turnaround time for their results is short. And we've worked extensively with employers and with public health departments across the metro to be able to offer testing in a way that provides answers as quickly as possible to those organizations as well. And to date, out of that 103,000 and change total tests run in our lab, 6,267 have been positive, so just over a 6.1% positivity rate. And you might ask, well, we hear that the positivity rate in our state is over 20% now for all specimens collected, or in Missouri, it's higher than that 6%. And that's true. There's a lot of good reasons for that. One of them, though, is we're doing a lot of screening tests. So most patients being tested in the community remain symptomatic patients, or those who've had a close contact with a known positive. In our case, though, because we know that having a surgery, for example, or a procedure while you're acutely infected with COVID, even if you're asymptomatic, can lead to poor outcomes, we continue to screen everyone for those procedures who's coming from home, or everyone who's admitted to our hospital, to make sure that we know that the positive patients are being treated appropriately and are cohorted and separated from the non-COVID patients in our hospital. So because we're doing such a large amount of screening for those patients admitted to the hospital or those patients having a surgery or procedure, our positivity rate is just a touch lower. There are probably some other reasons for that as well. We're testing healthcare workers more frequently and a number of other things, but that should help explain a little bit why that number looks so different from the 20% right now for the state of Kansas. So, Dana, anything that makes you want to add?
Yeah, I mean, just as far as the average age and the pre-existing medical conditions, you know, just this week I saw one of our local firefighters who was younger than the average age and had no pre-existing medical conditions and came into the hospital because he had COVID-19. He's discharged now. Hopefully he's doing better and able to get back to work, but it's so vitally important to keep everybody working. Essential workers such as police officers, firefighters. One of our favorite patients, Anil, you know, delivering goods from one place to another, you know, trucking. All of these things are very important, all our supply chain. So it is very important because we are seeing the age is decreasing. And even if you're young and have no other medical problems, you have a risk of getting hospitalized. So.
Very true. All right, Jill, let's get to some of our community questions.
Yes, and before we get to the ones that we've compiled Monday through Thursday, we have 4 quick clarifying questions. All right. Isaac wants to know the numbers that you're giving and the 7-day average of new cases differs from what Channel 9 gave earlier this week, and he wants to know how that works.
Yeah, so the slides that we've shared, the numbers here, are pulling from publicly reported numbers that are compiled across the country. You can see in the slides, if you review them, in the upper right-hand corner, there's a date range. And so these slides were through October 22nd. That was the last full day of compiled, publicly reported data that was available. I'm not sure of the source or the date range for what you might have seen from another news outlet or a specific source, but that is the source here. And these come from the COVID Tracking Project, so these are available for anyone. These are not numbers that were compiled. These are publicly available numbers that you can go out and search for, covidtracking.org. You can grab states, regions, counties. You can do a lot of exploration yourself to answer questions you might have.
And there's probably discrepancies in one site to another, but it's probably not going to vary by much. I think it's important to pick maybe one or two and stick with those because there are going to be delays in testing. There's going to be delays at that website getting the information, things of that nature. But I don't think there's going to be large discrepancies. You know, Johns Hopkins has a really good site. New York Times has a good site. KansasCity.com has a good site for our local area. So pick one or two, stick with that. Overall, there's not going to be a large discrepancy in those numbers.
So to clarify, Channel 9 is not wrong,
No.
just different.
Every time we look at these numbers, they're a snapshot in time, and the snapshot and its source are important to understand. But I think I agree completely with Dana. The general trend or theme is not different between any source, and if you're trying to compare, is it better or worse, it's always a good idea to look at the same source over and over as you're figuring out what trend you're seeing.
Now make sure your source is accurate. And again, I think the ones that we've mentioned are pretty accurate. So.
Okay, Jan wants to know, what kind of things should she have on hand for caring for someone at home with COVID-19? She also wants to know what she ought to clean with, if the isopropyl alcohol, did I say that right?
Yeah.
If that's good to use.
Yeah, so any regulatory body has continued to recommend typical household cleaners for cleaning surfaces in your house. You want to focus on high-touch surfaces such as handles, light switches, things where your hands are going to touch frequently because those are the pathways for germs to be transmitted in your environment. And as far as alcohol, so you can use isopropyl alcohol-based hand rubs or ethanol as the active ingredient in a hand rub as well. Both are effective. Isopropyl alcohol is what we are used to with alcohol-based hand rub, but the distribution of that has been disrupted with the pandemic, so you will see more hand sanitizers with ethanol as the active ingredient. It's still effective. It will have a more alcohol-like smell than we're used to. So just be cognizant of the ingredients, the active ingredients on the products you're using. And then always with any cleaning product, the label is the law. So you'll be able to read the label, know exactly what you need to do with it. Most of them will now say that they're effective against coronavirus or SARS-CoV-2. So you can see that. And then you want to make sure you look at the contact time too. That's really important in cleaning and disinfection. That will tell you how long it has to stay wet on the surface you're trying to clean to kill everything you want to clean.
All right, on the then and now slide that you used, Dr. Weil, does that chart reflect COVID hospitalizations or all hospitalizations?
No, those are COVID hospitalizations only, so acute. Meeting the definition of acute, so not the recovering patients that we know have been here for 10 days or more after their diagnosis or their symptom onset.
Cindy got a flu shot, and then not too long after, she got a fever that was under 100. She wants to know, should she get a COVID test?
Have at it, Dana.
Well, I think it depends at what time frame after. I think we were really saying, you know, probably within that 24, 48-hour range, if that's what it is. I think we were probably landing on it. It's probably safe to say that's a post-vaccination effect rather than actual COVID infection. So.
All right, and the last question before we go to the ones that we amassed over the week. Is the COVID crisis, is the end of it just around the corner? And is it going to disappear? Legit question.
Yeah,
I would say all signs that we have shared today, all signals that we have say this is not likely to disappear. And it sure doesn't look today from where we're sitting, whether you're looking at national numbers or whether you're looking at the impact on hospitals. If you're seeing the patients that are here every day, it sure doesn't seem like we're around a corner. I suppose, right, at any point we could see a turn for the better, but as of now, I can't say that we've rounded a corner.
No, I agree with you, and I think thinking about is this going to end abruptly? It's not. There's so many components to this, and there's a lot of talk about a vaccine right now that will help us tremendously. But all the components of preventing the spread of this are ultimately going to help us with this. And you can't rely solely on masking. You can't rely solely on distancing or a vaccine in itself, because it's going to take all of it for us to really stop this.
Okay, we have 10 questions from the week that we pulled, and let's go to the first one. If one is contagious for 10 days past symptoms, what is the timeline for asymptomatic people who test positive?
I'll let Lance.
Lance?
Pretty easy. It's
Well,
a good one. It's a great question.
Yeah, so it is a good question, and it's difficult to know exactly with asymptomatic people because we typically it's hard to observe asymptomatic people because you have nothing to go off of, right? So with symptoms, you can really focus on who you're counting and when, and know exactly when their infectious stage started. But we know that if you have a positive test, a good rule of thumb is that 10-day isolation that we apply to anyone who have mild to moderate illness. Now, if you become symptomatic within that time period, I think it's important to look at those guidelines and see that we want resolution of symptoms before you're out of your isolation. No matter if you're past or at 10 days or not, you still have to wait until you're no longer symptomatic. And that's also a really important consideration if you're negative for coronavirus and then you get sick with the flu. Same rules apply every season we had before. If you're sick, you should stay home. And so making sure that don't rely on, because everyone's going to be masked, that you can leave when you're symptomatic. You can go to the grocery store, things like that. We want you to stay home. And so it's a little hard to measure asymptomatic, but we know that mild to moderate illness, 10-day isolation is appropriate for those people as well.
Yeah. And if you're asymptomatic and say you develop symptoms and you have a test and then on day 8 or 9 you develop symptoms, you really need to reset that and you now have to be isolated for 10 days from that symptom onset. I think that's important to know.
And then building on that question is the next question. If I am symptomatic and I tested positive, when and for how long am I contagious?
Mm-hmm. Great question.
Yeah, so so mild to moderate illness, no one's been contagious for longer than 5 to 8 days. So that's why 10 days is a really safe time frame for that. So if you don't need to be hospitalized, that 10-day period is going to be critical for you to follow that isolation.
Yeah, we would really say probably 1 to 2 days prior to symptoms is when you're most infectious to 1 to 2 days after. After that, your viral load, the amount of virus in your upper respiratory tract significantly goes down. It's very difficult to culture any replication competent or infectious virus, say after about 8 days. Certainly there's going to be outliers, but for the majority of the population, right now the best data, and again, there's little data, we are still looking at those questions, but the best data would signal that really after that 8-9 days, you really shouldn't be infectious. But again, that should not stop you from doing the important things, masking as barrier protection, physical distancing, not going out if you otherwise have continued symptoms, and especially fever. We need to make sure your fever is gone for 3 days before that happens. And again, adequate hand hygiene as well.
I think it's really important to emphasize here and to reiterate that we're talking now about the 10-day isolation period for patients who are known positives, which remains completely different than the 14-day quarantine period for those that have been exposed. Remember, 14 days is up to 14 days is the incubation period, the amount of time from exposure to when you could become positive from that exposure. And so there's a difference. And unfortunately, you could be quarantined for 10 or 11 days after an exposure, then become symptomatic and test positive, and your 10-day isolation starts, as Dana mentioned, from that point. So remember, quarantine is for exposure, isolation, and the 10 days is after testing positive.
All right, my dentist office is not ventilated. They say they clean everything with a UV lamp. Am I safe?
Yeah, so I would want to look more into what does it mean to be not ventilated. I think your focus in a setting like a dentist's office should be really looking at do they have a masking policy in place that everyone has to mask? Are they showing that they're distancing? Do they have like a scheduling process where you're not waiting in a crowded waiting room? Those are the things that I would look for in a dentist's office to make sure I'm safe. There's a lot of question around ventilation, and most regulatory bodies will say avoid places with poor ventilation. Well, what does that mean? And so that means movement of air. And so you want to make sure that there's not stagnant air where you're at. So that goes for, if you're really in any setting. Most places where healthcare is being performed, there will be fairly good ventilation. And so I would say focus on the masking and distancing policies in those places. And with the cleaning and disinfection, UV light has use in some instances, but I would be more concerned with that the dentist's office is utilizing the same disinfection and cleaning processes that they've used all the time, because those would still be recommended in these cases. So they're held to a standard based off of their local health department. So those would be sufficient in keeping you safe as far as equipment and tools that they use.
All right, some voting places have 2-hour waits. Is that safe, and could a breath cloud hang in the voting booth?
Well, I'll maybe start with is that safe part, and then let Dana and Lance weigh in on the breath cloud piece. But I think the general answer here is the pillars of infection prevention that we have continued to reinforce apply everywhere, including at a polling place. And so physically distancing and wearing a mask will make anything, including a 2-hour line at a polling place, more safe than not doing them. And I think there are things that in many cases you can control. Of course, good hand hygiene plays a part in that. The isolating yourself if you have symptoms probably does apply as well. You shouldn't be going to vote, just like you shouldn't be going to the store if you are waiting on a test result or if you were symptomatic and isolated. But otherwise, I think just like we know those pillars of infection prevention help make other activities safe, I really do feel they apply the same way here, especially if the weather is conducive to having that waiting and distancing, being outside, and your close contact with a number of people is small. I don't know. Yeah. And the breath cloud conversation?
Yeah, it is all about risk mitigation and levels of risk. It is important, as you said, if you can be waiting outside. Obviously, when it's cold, it's going to be more difficult. But that's why it's important for the barrier, the masking, to be done by everybody in case you don't know you're ill. Again, the masks provide a barrier if you don't know you're ill, and you could be spreading the virus in the environment. Masks can also offer the wearer some protection as well, so that's important to know. But it's really that barrier. You can always wear the face shield along with the mask, not alone, or goggles to help with reducing the risk of catching it. In the voting booth itself, that's really difficult to say. Again, it's probably going to be more risk than being at home. It's probably going to be more risk than maybe just going through the grocery store, things of that nature. But you are in that voting booth for a pretty short amount of time. So would that even constitute necessary close contact? Now, do you think it's hanging in the air? That's very difficult to answer. If you have the barrier on, just as we saw in those hairdressers that had the disease, didn't spread it to any of their clients because both the clients and themselves were wearing masks. If everybody's masking, that's really going to reduce the risk that there will be smaller droplets hanging in the air or anything of that nature.
A CDC study shows direction, ventilation, and intensity of airflow play a part in spreading the virus. Please explain, and what does this mean for my family in a nursing home or myself at work?
Yeah, so kind of what I talked about earlier about really the key is movement of air and avoiding stagnation in air. So I think those are critical, and especially in places where there are positive patients. So that would be something that I think most people are looking at. We get consulted all the time for businesses, other places that want to open safely to take a look at those. So I think it's important to keep that in mind. But again, we have such great information on how important the masking and distancing is, and so I would say those take priority. And I know most nursing homes are looking at their environmental factors as well, such as ventilation, to try to enhance those as much as possible.
I would say really the ventilation issues at work or home are not going to play a large part in this. Yeah. That question is still being asked and looked at, but again, from what we saw in the Diamond Princess infections, the HVAC, the ventilation did not really prove to be a major part. I know that there are different treatments you can use for your HVAC systems, things of that nature. But ventilation, as far as Lance had talked about before, we don't want stagnant air. We want some turbulent flow, and that's why outdoors is better than indoors, things of that nature. But in general, if everybody is doing the distancing and masking and you're at work or you're at home, And if you can mask, especially if somebody is being isolated for active disease, that is not going to play a major part in spread of the disease.
All right, 12 of my family members want to come over for Thanksgiving dinner. If we eat in our 3-car garage, in our bubbles, spaced 6 feet apart, are we safe?
Well, I'd say that's a reasonable plan if you feel you must. And, I don't think we can answer specifically for your family if you must do something like gather with 12 people, especially if you don't all live together. And it doesn't sound like that's the case here. I think, in general, we would recommend as much as possible not spending time or having close contact with those outside of your bubble. If your family is able to bubble and truly keep everyone separated while you're eating and mask while you're not, again, good mitigation measures, and definitely better than not doing those things. I don't know. I mean, it's a tough question for a lot of families this year.
Yeah, I would be concerned about behaviors. You can have that plan, but then by the time everyone gets in there and maybe there's like drinks involved or something, you may be a little more likely to have close contact with each other. And, it's human nature to be close and gather for holidays. So we want to make sure that, if you're setting yourself up for that, I would say open communication with your family. And like I was talking about before, your bubble is only as good as everyone's behaviors in your bubble. So that's what I do in my family. We just make sure that we all have open communication. If one of us, say my brother goes to a big event, like he's not going to come to the next family gathering, so that's things that we do, just have open communication about what we're doing. And then I think it is a reasonable plan.
Yeah, I think the biggest issue is, as you both have talked about, is really the intersection of those bubbles. It's probably 3 or 4 different family bubbles at that point. With 12 people, I think there's a pretty good chance that one of them could be positive, just out of the pure numbers game and percentages. In a garage, I would think the ventilation is probably less than in a house, unless you're opening up the garage doors. But if it's 40 degrees, that's going to be difficult as well. So it's all about what is your ability to assess the risk and how much risk can you take. What are the other vulnerable populations that are taking part in that?
All right, do older seniors in nursing homes ever test positive for COVID-19 but are asymptomatic?
So from the published data, which is reinforced by even the Kansas State data, KDHE's data, the portion of the positive patients that are asymptomatic decreases as we get older, meaning a larger percentage of, say, 20-year-olds is asymptomatic than 80-year-olds that test positive. If the question is, does it ever happen, I am sure that there are some asymptomatic 70 or 80-year-olds in long-term care facilities across the country. But it's much less likely than in other populations.
Yeah, I think I would agree with you. I mean, I certainly know that we have seen, I have seen older senior patients here, not necessarily nursing home, but were admitted for one reason and were found to have positive COVID-19 and did very well, didn't have any symptoms. Now, can you say, again, I think this also goes to really what is asymptomatic, because we don't really know. Some of those symptoms can be so subtle, but in general, I would agree with what you're saying, yeah.
Right, we have 3 questions more. Isaac sent in this one. If the cytokine storm is caused by an overactive immune response, how can we be sure the vaccine won't have the same effect?
Yeah, good question. I think because so far we haven't seen that in any of the early vaccine trials. In addition, a lot of these vaccines, I think China is doing an inactivated virus. There might be one other inactivated virus, but a majority of these viruses, these vaccines, are either mRNA or DNA or protein. And really what those mRNA and DNA encode is the spike. So we are fairly certain, certainly from SARS-CoV-1 research, that the virus initially evades the immune system. It decreases what our body does to fight viruses, so that by the time our body catches up to that, that's when you can start to see that expressed immune dysregulation or inflammatory response. Just giving the vaccine with the spike protein in it shouldn't do that, as you are just creating the spike protein. You're not creating all those other proteins that the virus has to really decrease the immune system or contribute to that immune evasion early on within the infection. That's my best answer. But again, we haven't seen any evidence of that in the early vaccine trials.
One of the primary endpoints in each of these vaccine trials, so the warp speed, the 5 vaccine candidates there, and even the Pfizer trial, has been the concept of reactogenicity. So do you see any sort of big immune response, even something as simple, although it's not fun, but as simple as significant injection site reaction, redness, soreness, swelling of the arm, for example. So those types of concerns, the question you're asking, are really observed for as an endpoint in the vaccine trials. And to Dana's point, we've got no evidence so far that any of these 6 that are sort of front runners would have a significant concern like that.
Very good question. Yeah.
All right, and this came in from a teacher. Should students and teachers wear eye protection like healthcare workers do?
Yeah, so the reason why healthcare workers wear eye protection as a standard now with any patient encounter is to account for the reality that there's several reasons why a patient may have intermittent masking themselves based on their physiological needs or a treatment that they may have. So it's reasonable to add the eye protection to ensure all of your mucous membranes are covered, have that barrier protection. If there's intermittent masking with someone you're interacting with or individuals you're interacting with. So I would say it's a reasonable approach to add the eye protection for a teacher if you're with young kids who maybe they're not keeping their masks on all the time. It's definitely a doable I think increase in your PPE that you could do.
Yeah, I've recommended it for my son. Do I think he'll do it? No. He'll probably just put it in his backpack. But he needs to be on the bus and in class, absolutely. And that goes for everybody in the schools. I think it's a very good practice to do. So.
Yeah.
And our last question today, if my senior family member gets a vaccine before the rest of the family is eligible, that phase 1, 2, 3 approach, will it be safe to visit that person?
So a lot of unknowns in this space, and I think we have to start with the first being we don't actually have a candidate that has reached the stage, a vaccine candidate that has reached the stage of EUA approval to know how to answer that question. And the reason I say that is I mentioned there are different primary endpoints for each of these studies. Some of the vaccines are looking at an endpoint of, do you end up in the hospital? So they're trying to reduce hospitalizations, but not necessarily infections. Others are looking at deaths, and still others are looking at actual infection numbers. And so since each of these vaccines could have a different benefit, we don't have an answer to those questions yet. It's really hard to know. If, for example, one of the first vaccines is good at reducing hospitalizations, but not at reducing infections, and still would allow those that are infected to spread to others, that would not be a good candidate maybe for healthcare workers, and the phasing may change, but it might be a great candidate, a great vaccine option for those in long-term care facilities. So until we know more about the actual vaccine, it's really hard to give you any specific guidance there.
And I think until we know more, right now, today, just getting the vaccine's not going to change the fact about masking and social distancing and hand hygiene, the things that we've been talking about. But we are certainly excited to see new data come forth, and we'll continue to look at that and find best practices.
All right. Well, thank you all for a series of great questions, some of which don't have easy answers, and I think we're finding that is becoming more and more the case lately. Yeah. A couple of housekeeping notes as we wrap up the update this morning. For the reporters on the line, remember at 11:05 sharp today, right here from the studio, there will be a virtual news conference with Eric Hargan, the Deputy Secretary of the U.S. Department of Health and Human Services. He is in town today to meet with healthcare leaders from across the region and with providers to talk about the impact of COVID-19 on our hospitals and our patients in our community. For those reporters wanting to join, you'll be able to use the same phone and connection information as you do for these morning updates. We are confident for all of our viewers at home that news stations will carry pertinent details of that news conference, that update, on their shows later today. So watch your favorite news channel for that. And Monday, we're lucky to have two very bright minds joining us to answer your vaccine questions, the ones that you've asked this week and many more about both the COVID-19 vaccine and vaccines in general. Dr. Maria Salate, the chair of the Department of Internal Medicine here, and Dr. Ojo, the executive dean of the School of Medicine here on the Kansas City campus, will join us. They're both experts in this space. So, Dana, Lance, thanks for joining us. Lance, any final thoughts today?
As we get into cold and flu season, moisturize your hands so you have intact skin that's healthy and protecting you from germs.
There you go. That's a new one, and a good one, too.
Good tip.
I would say, we are heading into the weekend. There's probably not much to do waiting for the Chiefs to play. Go get your flu vaccine. Just saw a new study from the VA hospital that showed people with COVID-19 are 5 times more likely to get serious complications, including mortality, respiratory distress syndrome, stroke, things of that nature, compared to influenza. We certainly don't want to get both of those, so please go out and get your influenza vaccine. Influenza activity right now in the United States is still very low. You have time to get the vaccine, and your body has time to build up immunity when and if it does increase in activity.
And I'll ask everyone to not let your guard down as we go into the weekend. Last weekend, I went to a local restaurant to pick up our carryout that was supposed to be curbside delivery. And after 20 minutes of waiting and a number of phone calls and no food, did run inside. And what I saw was not particularly encouraging. While it's great, of course, that the restaurant was full from the perspective of those employees that work there and our economy, there was not 3 feet between tables. Everyone in the restaurant was eating and drinking and having a good time, but very, very few had masks on. The bar was shoulder to shoulder and too deep. And I know that we're all tired of this. We continue to talk about the weariness that comes with months on months of these same messages that are hard to hear. But please, for the sake of your family, those you care about, those that you love around you, and our entire community, don't let your guard down this week. So, as we head off into the weekend, Dr. Stites does have some final words of wisdom and some commentary on what happens when you don't follow the pillars of infection control. Take care, stay safe out there, and we'll see you Monday.
I think it should be a lesson to all of us that SARS-CoV-2 doesn't really care who you are, doesn't care about your income, doesn't care about what state you're from, what political party you're in, the job you have. SARS-CoV-2 is indiscriminate in who it attacks. And if you set yourself up to be vulnerable, it will come to you. And that's really, to me, that's the message. None of us is immune from it. All of us are susceptible if we don't follow the pillars of infection control.